Let me call this meeting of the Health and Human Services Committee to order. We do have a quorum. You will notice that we have much less members here than usual. I think that's because Appropriations has started meeting on top of us once again because they have started work on the 2018 budget. So thank you to all the members that are here, and I appreciate you showing up for the most important meeting, but you don't have to tell Chairman England that I said that. No, seriously, it's okay. Okay, first on the agenda, since opiates are such a problem, and Wellstar Health System has come up with something that they think will help with their physicians in ordering of opiates, and have been willing to share that, I invited them to come today. So, Wellstar, you're on. If you'll introduce yourself and
Sure will.
Tell us who you are.
Okay, Madam Chair, ladies and gentlemen, my name is Dr. Debbie Dalton. I'm a pediatric emergency physician with the Wellstar system, but I'm also the Vice President of Medical Affairs for Douglas Hospital, Wellstar Douglas Hospital. I had the honor of being nominated to be in a class called the Georgia Physician Leadership Academy, and part of that class we had to prepare a project. And one of my fellow physicians who had graduated the year before I did decided to look at the Think About It campaign that is something that's sponsored through the Medical Association of Georgia Foundation. And he did a little bit of work with that as his project. Well, I decided to expand on that. And what my project is to create a video that would be approved through Wellstar, and that every physician, nurse practitioner, and physician assistant who was credentialed to work within Wellstar had to view this video. Every 2 years we have a Safety First program, and you have to view the Safety First video, and it teaches them safety tips and things that we need to do to make sure that we're not having medication errors or missing certain things in patient care. We decided we were going to tie this to the Safety First program. So every physician has to see Safety First and in this video. I had to take it to the med execs. It was wholeheartedly approved by, at the time, only the 5 hospitals that we had, but it got grandfathered into all of the Wellstar hospitals, so all 11 hospitals. All their physicians, nurse practitioners, PAs have to watch this video as part of their credentialing process, and they cannot work at Wellstar unless they have this. So I'm going to show you this video. It's 7 minutes or so, and it does have some questions at the end for the physicians and other medical staff to answer, so that it proves that they actually watched it. And it's meant to give them some information about what's going on, what the statistics are, and what they can do about it. So I'm going to go ahead and start it. Let's try this again. There we go. Maybe. Sorry. If it does work. Oh, here it goes.
Let's review some important statistics. Opioid addiction has become a leading cause of death in the U.S., and its rate has quadrupled within the past 14 years. 16,235 people have died because of opioid overdoses just within 1 year from 2012 to 2013, and 37% of all overdose deaths during that year were due to medications which had been prescribed by physicians. Heroin overdoses have increased as well, and the reason why this is important is because most heroin users had first become addicted to prescribed opioids and then required a more potent drug to sustain their high.
Just this video, they actually have to listen to every single thing before it can go to the next slide.
The emergency department bears the brunt of opioid users and abusers with an increased number of visits to the ED, increased number of admissions rates due to complications or problems arising from their opioid use, the increased number of prescriptions that need to be written, as well as the care that is provided to traumas and overdoses related to opioid usage. It is important to remember that non-medical usage of opioids has dramatically increased, and that physicians are actually prescribing medications to these types of patients. Many people are sharing their medications, and a large portion of opioids are obtained from a friend or family member. They are either given to them or taken from them. Overdoses are also more likely to happen to those who are chronically taking opioids as they increase their doses to try to relieve their pain. The Think About It campaign was started by the Medical Association of Georgia Foundation, and it is sustained by volunteers and donations. The MAG Foundation wanted to increase awareness and solutions for the opioid epidemic, which was spread throughout the country. These are renderings of brochures and posters which have been printed and distributed by the Think About It campaign in Georgia. The 4 main directives of this program include educating patients on taking medications as prescribed, not to share medications, storing medications properly, and finally, disposing of unused medications so that they don't fall into the hands of people that they were not prescribed for. Other activities initiated by the Think About It campaign include setting up drop boxes for the unused medication. In addition to drop boxes, brochures, and posters, at Wellstar, we have included information on the lower portion of all printed prescriptions. The Think About It campaign was instrumental in helping pass the medical amnesty law, which helps make naloxone available to first responders as well as friends and family members of opioid users. Naloxone, also known as Narcan, can reverse the symptoms of an opioid overdose within 2 minutes, and there are several ways to administer it. Chronic opioid users and abusers may experience withdrawal symptoms when they are given naloxone. So what works to help decrease the use and abuse of opioid medications? There is a 3-step approach to patients who may be overusing or abusing opioid medications: monitoring of prescriptions, the use of naloxone, and medication-assisted treatment. By monitoring the prescribing of these medications, patients at risk can be identified. Also, physicians and other prescribers can be identified as possible enablers. Doctor shopping or emergency department shopping can be identified, but there must be proactive data sharing to be able to accurately identify all aspects of prescription and medication handling. Naloxone has saved over 10,000 lives since 1996. 23 states allow naloxone prescriptions to be given to the opioid user as well as to friends or family members who would administer the naloxone in case of an overdose situation. Autoinjectors and intranasal naloxone are easier to use for those who are not in the medical profession. To help opioid-addicted people, we must also provide therapies which will decrease the quantity and frequency of opioid usage. Medications such as methadone, buprenorphine, and naltrexone can help decrease opioid use. Project DAN, or Deaths Avoided by Naloxone, has also helped disseminate information on naloxone use for the general public and has encouraged its use at many levels. Project DAN ties the same information as the Think About It campaign and has provided funding for many counties in Georgia to have naloxone available to them. So what can providers do to help? Always review your patient's medication lists to see if they are being prescribed opioids frequently and by whom. Ask them if they have been taking opioids for pain. Always discuss the directions for the medications you are prescribing and try not to prescribe larger quantities than necessary. Talk to your patients about the potential for addiction when you are prescribing an opioid and tell them to store them properly so that others cannot access them. Always consider a naloxone prescription if you feel your patient is using these medications chronically. Enlist family members to be involved in your patient's care. Explain dosages, timing, and the potential side effects along with the potential addictive properties so that they can help monitor any issues that may arise. Remember that all of our staff members at Wellstar are encouraged to speak up by using ARCC, ask a question, request a change, voice a concern, and follow the chain of command with regards to any patient safety issue. Listen to the concerns and options voiced by others on the patient healthcare team. Do not be afraid to speak up yourself. Let the patient and any family members present know that you are concerned or that you feel the patient may be addicted. Explain options for pain management and other treatment options available. These patients may be at risk and you may save someone's life. Ridgeview is a local resource for Cobb County and most Wellstar hospitals. Their phone number is 770-431-7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032. 7032
they've actually listened to the information. So what I ended up doing is I was able to present this to the Georgia Hospital Association, and then I also was able to present it to Vizient as well, which is a national company that has hospitals involved in it. So, and all of them have asked for having some kind of access to this video. Now, this one is proprietary because it's got WellStar's name all over it, and it does need to be a little updated. There are a few other resources that are out there, and some of the numbers need to be updated as well. But what I created was a generic version of the slides that were made into this video and a narrative. So this is the narrative. So you can see that I have the same information in a video, and this is what I've shared with Vizient and with Georgia Hospital Association. So part of my project was not just bringing it to WellStar. It was intended that if I was successful with bringing it to WellStar, that I would help spread it throughout the state. So Medical Association of Georgia has been very helpful in trying to get me to present this as much as I can, and Madam Cooper also. So I'm thrilled that I was able to bring this to WellStar and get to all the 11 hospitals, and now hopefully to the rest of the state, if not the rest of the country. It would be great. So I'm willing to share that it's not proprietary information in the narrative or the slides. It's all information that's on the Department of Public Health website and CDC websites. Is all available information. It's just put it together so that it's easier to digest and easier to disseminate as well to other people. And that's my presentation.
I have a question then. So basically, if there was someone here that wanted their home hospital to use this, you've made the generic part. They can put their logos and everything on
Exactly.
it, just like they had done it, to show it to their physician and their staff.
Exactly.
It seems pretty bland as far as, any real in-depth. And I'm not being critical.
No, I understand.
I wonder is this a first step in starting the discussions with the physicians over how they prescribe, or how do you see this working?
This is definitely a first step. Opening up the dialogue. A lot of physicians feel that it's not their problem, not their job, not their issue. Pediatricians also feel like they don't need to be worried about this, but they do, because I've certainly seen it working the pediatric ER. I've seen parents come in with a child who had a sprained ankle and requesting narcotics for it. So it's out there. So this is a first step, and it was a year-long project, and that's why I had done that. But again, we're going to expand on this. So I don't know if the physicians who are in the Georgia Physician Leadership Academy this year are working on something like this as well, or expanding on this process. But it was a way to be able to open the dialogue, start the conversation, and maybe be proactive in taking care of patients who may be addicted.
Representative Sharper, you had a question?
It's just automatically blinking without.
Pardon?
I said it's automatically blinking without. I did it by mistake.
Okay. Other questions from the Representative Jaspers?
Yes, ma'am, Madam Chairman. Just, it's loud today. I guess a question for our presenter and you. Have you seen any data that's shown there's a decrease in writing prescriptions, numbers, or anything like that to kind of validate?
I don't think I've seen anything in terms of decrease in the number of prescriptions. I think it's on everybody's mind, but I think practices are very, very similar. I think it probably a little bit better, but not enough, I think. So that's why we needed to get the word out and get people to really understand. This has only been, this video went live in September, October, so because we had to tie it in with the other process as well too. So it hasn't been super long yet that we've had this live, but we were anticipating that there's going to be some change. How much we don't know. We're going to definitely monitor it.
Yes, ma'am. Thank you.
I can tell you from the drugs and narcotics, Mr. Allen, there has been a measurable drop. It's not huge yet in the number of prescriptions over the last year and a half. It's not huge, but there has been a drop in the number of prescriptions written. So we are making some headway. And I will tell the committee that the Board of Medicine, thanks to my browbeating them and telling them, I'll just be truthful, that if they didn't do it, we were going to do it, or now have just put out the rule where they will require that all physicians have continuing education on opioid, and they are specifying the course that they have to take as part of their continuing education. So the board doesn't like telling physicians what they have to do in their continuing education, but they felt like this was a big enough problem that they were willing to do that. So it's out for comment now about the rule
And
change.
we're also focusing on the graduate medical education, all the residents who are starting. We have a new program at Kennestone, the program at AMC, and they're all getting this education as well.
Okay. There are other questions? Thank you very much.
Very
Did y'all have,
I just wanted to thank you for recognizing the work that's going into this and for your encouragement with us to get it out on a statewide basis to the Georgia Hospital Association, the Medical Association of Georgia, and through other channels.
okay.
For all of us today.
Well, I appreciate you sharing it. Ran into a little snag, and we had to get the snag done, and Wellstar was, and the head of Wellstar, Candace, was, what is Candace's last name? I just called her
Saunders.
Candace. Candace Saunders, who's the head of all the Wellstars, was very nice in meeting with me and being willing to share this, to take their logo off, to absorb the cost, and to be willing to share it with any hospital across the state of Georgia. So thank you very much. We are working on this issue, and there are bills presently in the legislature, various bills going from where we are totally free to where we lock it up so tight that I'm afraid patients can't get the medicines they need. So hopefully we will find also a first worthwhile step and not go too far drastically either way. So I hope Wellstar will be involved in that discussion as it goes forward.
Yes, Madam Chair, and thank you for your thoughtful approach.
Okay.
And I'm very willing to help out too. In any
Okay,
way I
thank you very
can.
much. Pay
Please.
attention as the
Thank
bill
you.
goes along,
Thank you for the
and
opportunity.
thank you very much. Thank you all for coming. Okay, let's see. Okay, Representative Price, let's have House Bill 165. You ready?
Thank you, Madam Chairman and members of the committee. I bring before you today substitute House Bill 165, so it carries the number LC 336842S. And this bill brought primarily from the Medical Association of Georgia is basically to define a couple of terms, maintenance of certification and specialty certification, as I think you all see in front of you. And the basic specialty certification that people get, physicians get after they have their license or after they have extra training, is what we call board certification in a specialty that that they do beyond their basic internship. Now, the Georgia Composite Medical Board is what is the licensing entity, so it basically has nothing to do with specialty certification. So specialty certification is above and beyond an internship and includes whatever area that you go into beyond an internship. And specialty certification, as was defined in other portions of the code, are given by two entities, American Board of Medical Specialties or the American Osteopathic Association, that provide board certification that's recognized. The other definition in this bill is the maintenance of certification, and that's the annual or decade or whatever interval after one gets his initial board certification, and they call that the maintenance of certification, or MOC. So this is being defined as a continuous professional development program through which physicians certified by one or more of the specialty boards maintains that specialty certification. So the crux of this bill, though, is in B, line 18, where nothing in this bill shall be construed to require a physician to secure maintenance certification as a condition of licensure to practice medicine pursuant to this article, or as a prerequisite for employment in state medical facilities, reimbursement from third parties, or malpractice insurance coverage. And if you have only seen the original bill, what is removed from that is hospital staff privileges. So that's the difference in the substitute and the original bill, and I'd be happy to entertain any questions.
Okay. Representative Newton?
Hey, thank you, Dr. Price. A quick question to specialty certification. Is that a change when it says the one, number one there, line, I guess 14 and 15 spell out the two specialty boards that are most commonly recognized, but then down, I guess in line 16, it just says specialty certification means certification by a board. Would that be understood to be one of those two boards that we just mentioned?
It does seem a little confusing. If I had been crafting this, I probably would have put two before one. They're kind of backwards, but yes, what you say is correct.
Okay, so it is meant that to the public, when we say specialty certification, we mean by the medical specialty boards or the American Board of Medical Specialties or the American Osteopathic Association.
Correct. That's the initial board certification. Yes.
Okay, this doesn't change that somewhere else in this article or not? or
No.
does it? Okay.
I don't believe so. No, last year there was a bill that was requiring people who claimed board certification to be board certified in one of those two, from one of those two entities.
And this doesn't change that?
This doesn't change that at all.
Okay.
No,
all right.
this is primarily talking about maintenance of certification
Okay.
and how that's defined and how you can acquire it.
Thank you.
Representative Price, I don't think the committee really, I think we need to put this in plain language. Let me see if I can help you do that. Maintenance of certification. Tom was boarded, his basic boards were in family practice. Okay. Family practice boards require that every 7 years you take another exam to be reboarded. Okay, and if you don't take that exam again every 7 years, you cannot say that you're boarded in family practice. And some hospitals require that you be boarded in your specialty to be on their staffs, correct? Am I
Correct.
correct so far? Okay, so is it my understanding that what we're doing, take out the hospital portion. Hospitals can still require that you maintain your boards. And it was, family practice was 7 years, I think orthopedics, was it 10 years? They have different times that they allow. But this would mean that an insurance company could not deny you payment just because you chose not to go and take that board again.
Correct,
And
beyond the
it-
initial.
I mean, that
Or,
you could-
well, they can
Right.
set their own standards, but this is to say that they can't discriminate between
Right.
someone who does or doesn't have maintenance.
that they're not repeating and keeping
Correct.
that board certification up. Once they're boarded, they were boarded once, but if they choose not, as an orthopedist, every 10 years to go take that exam again, then the part in Part B, you can't use that to keep them from being paid or so forth. Correct?
Correct.
Does that make it?
Which is not to say that they're not getting continuous medical education as required by the Composite Medical Board in order to maintain your license. So separate things. So they are required to have additional and routine every 3 years, I guess, however often you get your license. 2 years. 3 years? It's 3, 4? How often do we get our license? 2 years?
Every 2
Okay,
years.
every 2 years, you have to do whatever it is.
Are you up to date on your continuing education?
I'm going to go home and check.
Don't turn your back off now.
The years just go by, you know?
Yeah,
It's-
it just is.
They do. So in order to maintain your license, you have to do these certain number of hours every 2 years, as has been defined and legislated by this body.
Okay, and this recertification can be extremely expensive. I think the cost of it is one of my understanding, and I know that Tom Cooper, shortly before his death, was getting ready to start studying to be recertified once again, but he always complained because even though he was boarded in family medicine, in the boards, you have to pass it on OB and pediatrics, even though he hadn't seen an OB patient or a pediatric patient probably in 30 years. So, I mean, there are some reasons that people choose not to be recertified. Like they
Yeah.
don't work, like he didn't deliver babies or do that. He could have decided not to
Yes, so
recertify.
usually as people progress in their careers, they subspecialize or they become known for one area that they're particularly good at, and having to do a maintenance of certification that requires you to be tested on a much larger volume of information and knowledge, it's very, very difficult for people. And then they offer courses, and then you have to go and, study those. So it's costing upwards $10,000 to get your maintenance of certification, which probably doesn't assure that you're any better of a physician than you were just practicing what you're doing and doing well repeatedly and getting better as each year passes.
Okay. Representative Silcox.
I was just curious why hospital privileges was removed.
Because they are a private entity, and we should let any private entity determine their own criteria for employment or staff privileges.
Okay, thank you.
Representative Henson.
Thank you. What this bill is doing is saying you have to go back after X number of years and take,
No.
it's not.
No, it's saying that if you want to, you're certainly welcome to, and if a certain employment situation requires that, then we're not going to intervene. But it's saying on the basis of those items in lines 21 and 22 that they can't require it.
Okay, because the statement that the chairwoman said is the same thing I dealt with my dad, was he became a specialist, and when you send them back to take exams, it's dealing with issues they haven't dealt with in 10,
Exactly.
20, 30, or 40 years. Okay, thank you.
So you can go out and get any sort of certification of sorts that shows that you have done different and additional things beyond the original. It's just you're doing that for yourself or for any entity that wants to connect with you, but it's not going to be required, and it's not a condition of licensure.
I'm on. Requiring CE hours is totally different than requiring one take exams again.
Correct.
Okay, because I'm very much in favor of the CE hours.
Right, and that's not going to change. That's in a different portion of the code.
Okay, thank you.
Okay. Further questions? Okay, when you have any questions, we had a sign-up sheet. Do you have it? We've got it. Does anybody would like to speak to the bill? Identify yourself and.
Hi, my name is Bethany Scherer with the Medical Association of Georgia. I want to thank Representative Price for her work on this, and Madam Chair for helping explain the bill while we were up here. We are in total support of this bill, and we see maintenance of certification as essentially physician red tape. And I'm here if anybody needs further clarification or has any other questions. All right, thank you.
I will tell you that I've had a couple of physicians that are retiring because they were going to be required to go ahead and do this again, and they were nearing the end of their career where they were able to retire and just decided that it was not worth going through the hassle because, like I say, it's very rigorous, and unless you love studying like my husband did, they can really take a lot of time and a lot of cost, and they decided it just wasn't worth practicing anymore, and we're losing a couple of good physicians, and I'm sure there's more of them out there that I do not know about. So, okay, I'm ready for a motion.
I move do pass LC 336842S.
Okay, I've got a motion to pass and a second. Is there any further discussion? Not hearing any discussion. Everyone in the favor of the passage of House Bill 165, say aye. Aye. Anyone opposed? No. Well, the ayes have it. Thank you very much, Representative Price. All right. Let's take up House Bill 206, Representative Kelly. And this is the most misnamed piece of legislation I've seen in a long time. How did the pharmacy audit Bill of Rights get in here?
It got whittled down, I think.
Oh, it got whittled down, okay. And I know you didn't, I don't think you named it.
No, ma'am. I'm actually, no, Madam Chair, I'm actually kind of working off a bill that we had last year, House Bill 916. I just want to say how great it always is to be in front of this committee, but especially on Valentine's Day. I guess I would dare to say it's a real treat.
I thought this was a good bill.
Boy,
How lovely it is to be here.
you opened yourself up, guys. It's free range on him.
So, Madam Chair, we'll get right into it. House Bill 206 is a bill that comes back to us from House Bill 916 last year, a measure that passed this committee as well as the House unanimously, had one no vote in the Senate, and then through bill review with the governor felt like there was a section in the bill that was a little too broad. And it was one of the measures that he vetoed last year. We've listened to those concerns, and we have struck that part of the bill that they felt was too broad, and have came back with what is now House Bill 206, LC 336827. And what this does, Madam Chair, members of the committee, is that and the reason it talks about the Pharmacy Audit Bill of Rights is it removes an exception relating to certain audits conducted by the Department of Community Health. And what we've seen in the department's audit process and through their mechanism that they have a outside party who helps them conduct their audits and helps recoup certain costs from providers should there be certain errors traditionally. And a study committee was done on this in 2015, and no one here would dispute the necessity of auditing providers of services funded through our state government, DCH and Medicaid. But in this instance, we were seeing really what I consider a lack of common sense in the audit procedure. And they were going to recoup millions of dollars in cost throughout this program for clerical and Scrivener's errors. That wasn't the design of the program. We have these audits for providers that are acting in bad faith, or providers that are acting in a way that is in conflict with the program's goals, not for someone who may be at a lower level who's just helping fill out a form. And that's what this bill simply looks to do, is just make clear that any clerical or record-keeping error, and then we list off several examples of that, including but not limited to, shall not be subject to criminal penalties without proof of intent or to commit fraud, or the recoupment of the cost of medical assistance provided shall not be allowed if such error, omission, or incomplete documentation has occurred and has been resolved in accordance with subsection B, which allows a 30-day correction period. And so what we're looking at here really is allowing individuals where there are clerical errors to not have large recoupment of cost come back. Obviously, I think, and you'll hear in one instance here where the department came back in one audit for a provider who was providing certainly necessary services to Georgian citizens, where the department came back and asked to recoup $500,000 worth of cost for clerical errors. And to think of the disruption of cash flow and the hit that would be to a small business trying to help some of Georgia's most vulnerable citizens is simply unacceptable. And you'll hear more on that, Madam Chair. But that speaks to to this simple bill, and I'll be glad to answer any questions if there are any.
I mean, Representative Kelly, when you talk about clerical errors, are you saying that they put down for services twice by mistake, or that they overcharged by mistake, or they charged for the wrong service where it was more money? What kind of clerical errors are you talking about?
Madam Chair, these are not, I would look at, where someone is charging for multiple services and things like that. That would certainly be there are times where that would constitute fraud, but those are not what we're looking to reach here in the bill. We're simply looking for minor typographical errors, and I know we have some providers who can speak more to some of the examples that they saw in instances where they've had large amount of costs recouped that are not in the fraud vein.
Yeah. How about just not putting their signature on certain pages?
That, I think that would be one specifically.
One of the kind of things that they were doing.
Yes.
Okay. Questions. Let's see. Representative Petrie, were you one of those people that got hit?
No, not at all.
Good.
But I wanted to mention, Representative Kelly, thank you for this bill. I wanted to mention, I was on that study committee you alluded to, along with Representative Harden, who just left his, if he made it in as well. We had a natural resources meeting I had to speak to. But we were both on that committee, and kind of to speak to what Chair Lady Cooper asked, most of these omissions were I's that were not dotted and T's that were not crossed. They were signatures that were not made, where maybe there wasn't a signature here, but there were signatures made on 10 of the pages, but not in one location where they should have been made. They were really things that were absolutely not fraud. And so on that committee, what we heard was that we need to be more aggressive on dealing with fraud and recouping from the bad guys. But where you've got good providers who are serving people in the community in good faith, and the example you mentioned, the $500,000 case, was a provider of adult day services for developmentally disabled individuals, where nobody refuted that those individuals were there every day and that they were taken care of every day. It was all about that signature that was missing in certain locations. And so I just wanted to emphasize that, and again, thank you for carrying the bill.
Representative Petrie, I know the work that you do and the services you provide our state, and the work that you did on this study committee along with Chairman Harden and now Judge Dusty Hightower. So thank y'all for the work that helped get us to this point.
Okay, Representative Broadwick.
Thank you, Madam Chair. Representative Kelly, you explained the bill very well. These are simply Scribner errors with no intent for fraud. And with the audit, that the auditors have got to give sufficient time for the provider to prepare for an audit. That's part of the Bill of Rights, Audit Bill of Rights. Sufficient notice ahead of time to prepare for the audit. And as long as it's without any intent of fraud to defraud the department in any way.
You're absolutely right, Representative Broderick. That's the absolute intention of this bill, is to make sure that we're not punishing those who are providing these vital services, but that we're also still allowing the department the flexibility they need to go out against those who are looking to commit fraud in our state.
Representative Sharper.
Thank you, Chairman. Does this include coding as well? Like if you have a coding error, because I know sometimes they may not add a particular code that goes with a particular diagnosis. So I'm wondering, is that included in this?
I would maybe, Madam Chair, maybe we will have someone from one of the providers come up here and help me talk through the specifics of the coding question, if that's the appropriate time to do that now.
Okay, thank you.
Okay. I think we need to ask Betsy, our legal counsel.
Well, I was going to direct you to line 20, the code coding, unintentional error, omission coding.
Okay.
As long, the key here, Representative Sharper,
All
is that it's unintentional.
All right, okay, that's good.
Okay.
Thank you.
Representative Peak.
Thank you, Madam Chair. Representative Kelly, you may have said it and I just missed it, but the reason that bill got vetoed last year, what is the change that you made that would preclude that from happening again this year if it makes it all the way to the governor's desk?
So I'm going to pull up. I have the measure from last year. If you'll give me, we actually deleted an entire section from the bill. There was a section. Originally, this bill was 4 sections long. House Bill 916 was, and Section 3 had a statement particularly that was broad that said, in a department, an audit of any department or state agency, and the governor felt like that was just too broad, not limited specifically to DCH and what we were trying to
So you've addressed
accomplish
specifically the reasoning and rationale for its veto in this bill.
We've cut out about 40 lines of code to save our code books and also to make sure the governor is okay with the measure this year.
Okay, thanks.
There's no further questions, but we have people that do want to speak to it. Tina Blakely, when you speak, if you'll come up to the microphone and tell us who you're with.
Good afternoon, Madam Chairman, committee, thank you for this opportunity to speak this afternoon. I work with Soto ALG out of the Augusta area, and we provide services to individuals with developmental and intellectual disabilities. I am the president-elect of SPAD, Service Providers Association for Developmental Disabilities. We have over 100 member agencies in SPAD, and we serve about over 8,000 individuals in the state with intellectual and developmental disabilities. This program is through the Medicaid Home and Community-Based Waiver Program. And SPAD supports the importance of audits of the program integrity for, to help root out fraud and abuse for the services that may not be provided. The issue is the clerical errors. Some of the documentation requires the signature, a title of that person, the reaction of the individual that we're providing the services to. So if they're nonverbal, we would need to write down tears or happiness or other nonverbal cues. Or if they are verbally able to communicate that, then we have to write that down as well. A specific color of ink has to be noted in, and then a single line drawn through if there's an error, and then a name and a date with the word error behind it if there is an error. The now and the comp waiver services, the documentation is very complex and extensive, and for the most part is completed by the lowest paid employees in the agency. Some of the erroneous, I'm sorry, I'm nervous.
It's okay.
It is SPAD's belief that it is not the absence of one of the things that I just spoke about, but that the fraudulent billing and simple human and clerical errors should not be all lumped together. The impact of these audits are substantial to providers. When you are audited and you get a recoupment, that has to be paid up front, and then you can go through the appeals process after that. And some of these audits can range up into upwards of $1 million. And as Representative Kelly was talking about, that can be very devastating to providers, and some providers have even had to close their doors because of these erroneous and clerical errors. If there is an error, say a title after the signature, then the whole day of services is recouped. So if you provide services to an individual with intellectual and developmental disabilities for 6 hours, that whole day's worth of service is recouped just because you forgot to put the initials after your name. Right. There is, so be mindful that there's no evidence that the service was not provided. The services are provided, it's just clerical and minor clerical and human error. So again, SPAD is fully supportive of this bill. We appreciate your time, and if you have any questions, I'll be glad to answer those.
I don't have a question, but, I will make a comment. I understand about not putting your title or something like that. However, it is pretty important if you are charting because of the legal process that you do follow certain guidelines. I mean, I know it's the same thing in nursing, that you put one line through it. You don't use whiteout. You don't scribble it out. You put one line through it and, put ERA and initial it, or put so that we do it.
Yes, ma'am.
So, I mean, there are things that are extremely important that should be followed. However, I think if it's an occasional thing, we don't need out of control bureaucrats trying to make up excess to their budget
Yes, ma'am.
by taking away a whole day's pay for it.
Yes,
So,
ma'am, and we're not given the opportunity to correct that error. It's just a recoupment from the beginning.
okay. Representative Henson.
I'm not sure who, I think I need to direct this question to you. This is called the Pharmacy Audit Bill of Rights. Yet, if I'm not mistaken, we're talking about other things beside pharmacy. So is this broader than pharmacy?
It is, it's under DCH. The department's there, so it covers any of the audits for what's covered under DCH.
So it includes dentists too, and I've been through audits, believe me, and the recoupment process years ago. They're no fun.
Right.
Okay, thank
Okay.
you.
You're welcome. Thank you very much, Ms. Blakely. Lisa Sassaman? Got it right? Yes. Okay.
Good afternoon, Madam Chair and members. Thank you so much. I was here a year ago when the study committee first started looking at this issue. My name is Lisa Sassaman, and I'm Executive Director for the Griffin Area Resource Center in Griffin, Georgia. We are a small private nonprofit organization providing services to people adults with intellectual and developmental disabilities. We're an old organization just celebrating our 60th year, and we are proud to have been one of the first ARCs that came about in the state of Georgia in the 50s. In July of 2015, I received a call from a nurse from the Georgia Medical Care Foundation, and she was coming the following day to do an audit of our services through a now in comp waiver. She came in the following day. She reviewed 44 members. At that time, we were serving 60 people through the Medicaid waiver program. And she brought in a scanner and scanned the 44 member records. And then in a couple of weeks, we received notification through them that we were being recouped $452,000. Our budget for that year was just a hair over $1 million. But there was no fraud, there was no abuse. It was a lack of signature, DDP signature. As executive director, every person that receives services has an individual support plan. And because I signed off on the plan as executive director and not DDP, they recouped all of that money. It was devastating. And we were going to we were facing the thought of closing. We could not continue if we had to pay back the $452,000. We did not have the funds. We gathered together as families. It would have devastated our community because families, members rely on places for their children to go in the event so both parents can work. So I did what any person would do to save an organization is I reached out to WSB. I reached out to y'all. I reached out to whomever. Through a colleague, I hired an attorney, and we began to fight it. And unbeknownst to me, once word got out, other providers began to step forward. And then you could see that some providers were mortgaging homes in their residential program to pay recoupment. Just to bring you up to speed, months and months and months went by, and finally DCH decided to settle with us for a minuscule amount. So I can just tell you that I support this bill for that very reason. I believe that if you are providing fraud, if there's abuse or neglect or anything, that by all means you should pay back and either further action. But I just am here to share my story.
Thank you.
Do
How
you
much
have
did you
any
pay out in
questions?
legal fees to get that
It
minuscule?
was over $50,000.
Okay, thank you. Any questions, committee? Thank you very much for your testimony.
Thank you.
Okay, Steve. I don't think you have much to say after that lady.
No, ma'am, that's hard to follow up. My name's Steve Neff. I'm the Executive Director of the Georgia Association of Community Care Providers. Our group consists of home care, assisted living, developmental disabilities, home delivered meals. Obviously, many providers within our group have gone through the same thing. We thank the committee. We thank the study committee that came up with House Bill 916, which I certainly understand the governor's disagreement, but I felt was a good bill as well. We stand in support of this legislation. I certainly won't rehash it. The only thing I would say is that in our close workings with Department of Community Health, with Utilization Review, who are, we work with them dearly, and we consider them peers and colleagues. I do believe this had become kind of a gotcha mentality in those that work in this, in the medical profession and others. I can see this. I have seen, and I suspect Representative Petrie and others, there have been some changes just in when this bill came through last year. There's been changes to Utilization Review. This is much needed, and we do appreciate your support on the bill. I'd be happy to answer any questions, and to save time, I could answer them out in the hall too, if you may need.
Are there any questions for Steve?
Thank you, Madam
No
Chair.
questions? Okay, what's the pleasure of the committee?
Oh, DCH is not here?
Nobody signed up. Is anyone from DCH here?
I would have asked questions. I was holding off for them.
Okay, that's unusual.
Well, we've heard, can I say something?
Sure.
We've dealt with this back 2008, 2009, and thought we had things fixed. At one time, they were recouping for ink color, for signing a little bit off the line, and the people they hired were actually working on a percentage of what they recouped. All this is bad business from our DCH. So am I to understand that they no longer do this?
Pardon?
Lisa Marie Shackle with DCH.
Oh, good.
Hey,
Were
I
you
didn't see
asleep?
behind- Yeah, I didn't see you behind the collar.
Well, you could have been in trouble. We were just, I was going to make a call over to the department as soon as we got through and fuss.
She's one of the good
We're not going to get you in trouble, Lisa Marie,
No, I appreciate that. So,
as long as you weren't on your phone texting.
no, I plead the fifth. I plead the fifth.
Teasing. I'm teasing. I'm
Plead the fifth.
teasing.
So I'm Lisa Marie Shekel with the Department of Community Health, and certainly can answer any direct questions, and if there's information that I need to go back and get, certainly can do that as well. We were well aware of the bill from last year, House Bill 916, and of course aware of the governor's veto. We've taken a look at this current legislation, and really, if I have the opportunity, you just wanted to talk a little bit about some of those process changes that we've made that Steve seemed to reference in his comments. There is, as I understand it, a new corrective action process that has been put in place that we believe better engages providers on the overall auditing. There were some issues that we needed to address in terms of having better communication with providers, and so that process has been put in place. I understand that our Inspector General, as well as some of his staff, have attended various association meetings across the state and have talked with providers about this new process. As it relates to our current process for initial reviews, our main focus is on the members' quality of care and whether or not the services were actually delivered. So the intent is to look and recoup and find things in audits that are specific to that delivery of care. There were most certainly some concerns that were expressed by the committee, other members of the legislature, as it related to our former processes, and we believe that we've been able to address some of those issues. As it relates to adverse findings, we have streamlined the communication that goes back to providers in terms of what is actually found. I know that there were some concerns around the volume of policies and procedures that these providers have to follow. So in order to give better feedback so providers are clear on what our concerns are in that auditing process, we're trying to address that as well. As it relates to process changes, we have forgiven mistakes that do not affect quality of care issues, and where they're able to show that services were actually delivered. and areas that are recommended for forgiveness are for a first-time discrepancy. After there is that initial conversation and opportunity for education with the provider on what policies do exist, the expectation is that those policies would be followed moving forward. I appreciate the opportunity to share that information with you. I'm glad I brought that piece of paper, and I know I didn't have a chance to speak with you all before this. So if there's direct questions that you have, I'll do my best to answer them. Otherwise, I can certainly get information back to the committee, but do appreciate your
Okay,
looking at
Representative
this
Hawkins, you
issue.
now get to ask your question.
Just, yeah, thank you. This is one of the really nice people to work with, DCH, so I'm gonna go easy on her. But let me ask you this. How about the percent? Are the auditors still working on a percent of recovery, or has that been corrected? Or
I
do
would
you
have
know?
to specifically ask that question. I don't have that information. in
Yeah,
front of me,
I
but
thought
we'll
that
go
was
back.
pretty egregious to send the sharks out in the water after these folks like that. Okay, and so if they do a miscode, then that's not considered fraud any longer?
A miscoding in terms
Miscoding, like, just,
of requesting a,
the dentist, we had dentists, they were doing Medicaid, and their lady up front with all the different forms they have to fill out with the different CMOs and DMOs, we won't go into all that, may type the wrong number down to 4363 and they hit a 2 instead. And I was hearing from dentists that they were getting notes of that's considered fraud if they missed a number like that. Is that? Now, that was in the old days. That's been corrected too, right?
So my comments are specific to some of the issues that were brought up by the DD community, the DD
Right.
provider community. So
Right.
that, with that specific issue, I'd have to go back and
Okay.
check with folks.
Okay.
Okay. I mean, I think Betsy said, as long as it's not on purpose and the code includes the coding.
This
Okay.
is good.
Representative Henson.
Thank you. With regard to recoupment, such as we heard from the lady who testified, are you all still doing that, the huge recoupments, and then letting them incur a $250,000 legal fee?
So I don't have information with me right now in terms of what the amounts of those recoupments have been. What I can speak to is sort of the general process change that we've put in place, but if you're asking for specific numbers as to what that translates to, I can certainly go back to the department and ask for those
I
specifics.
guess what I'm asking is, are you just all of a sudden turning around and recouping and then begin talking?
Representative Henson,
Yeah.
if they've been doing, we're fixing to stop it.
Good.
Okay?
Because recoupment and then talking just
Right.
doesn't always work well
Okay.
for the providers.
And Lisa Marie can get you the statistics on how much up to this point, but we're fixing to stop it if it's just from pure errors and not truly fraud.
Speak to that, Madam Chair, and I'll just point Representative Henson as well to line 35 of the bill, and it talks about that a provider of medical assistance, and I apologize for leaving this out in my initial comments, that they will be afforded the right to a hearing prior to any of this withholding or recoupment. So I think that's an important due process piece to point out in this moving forward.
I mean, there certainly is fraud in our system. There's fraud in the systems all over the country, and I certainly tell the department, go at it after people that are truly frauding the government, because it takes money away from care away from the people that need it in our state.
Absolutely.
But on the other hand, we have really discouraged many providers from even signing up for our Medicaid programs because of this excess burden. Representative Silcox.
So thank you so much for joining us today. And I was just curious, given your explanation of your new processes, is DCH generally in support of this bill?
So I think relative to what we've done to address the bill, certainly as the legislature will allow you to make those decisions as it relates to policy. I think that we have demonstrated that we listen to the concerns of the provider community, demonstrated that we listen to the concerns of the legislature, implemented the process change, and kept the process change in place even after the House bill's veto last year. So, certainly as an elected official, we'll let you make those decisions as to whether or not that bill needs to be put in place.
Well, Lisa Mary, you'll tell the department and the commissioner we appreciate the changes that have been made, but, you know, we change and don't always stay down here, and sometimes the bureaucrats outlast us and the bureaucrats change. So I think that probably, if I get the feel of looking around everybody, we appreciate what you've done, and you can take that back to the department what they're doing, but we're just gonna make sure by putting it into law that it doesn't happen again. Now, I might be wrong. So at this point, I'm ready for the committee to tell me what you want to do. You want to make all the motions today? No, I'm teasing you. Go ahead.
Motion do pass LC 336827.
Okay, I have a do pass. Do I have a second? Okay. Is there any more discussion? No more discussion? Then everyone in the favor of the passage of House Bill 206, say aye. Anyone opposed? No. Well, the ayes certainly have it. Thank you to everybody that testified. And there we go. We weren't too bad to you, were? Okay. Representative Lott. Let's go with House Bill 210.
Thank you, Madam Chair and members of the committee. I will be presenting HB 210. I think the explanation on this bill might be a little bit longer than the bill itself. So this bill is an amendment to the code section 3122.1 and the current definition of clinical laboratory. HB 210 asks to exclude from the definition collection centers where the human blood and component parts are intended as source material only for the manufacture of biological products. Not to be changed in this section is the current wording for, on line 16, for collection stations and blood banks that are used for diagnosis, prevention, and treatment of human beings. So you've got a little sheet with some talking points on it. I'd just like to kind of go over a couple of these points, but plasma collection centers are such that the blood and component parts are used as source material only. These plasma collection centers are currently regulated by the FDA, Food and Drug Administration, the CBER, which is the Center for Biologics and Research, and CLIA, which is something that we addressed in last session as well, the Clinical Laboratory Improvement Amendment. Georgia currently has some plasma collection centers listed as laboratories in here. We have facilities in Georgia, but being listed as laboratories has caused increased regulation on these centers. The state of Georgia has regulations that are outside of what the federal guidelines are on these facilities. So what we're hoping to do in this legislation is remove these PCCs, the plasma collection centers, out from under the clinical laboratory definition. The FDA does require some staffing requirements in their requirements federally, but Georgia has an increased number of staffing requirements placed by the state of Georgia. For 2 years, BioLife centers, plasma collection centers, here in the state of Georgia have had a waiver of these additional regulatory burdens. And now what we are trying to do is exempt them permanently within this code section. This is similar to a bill that we sort of ran last year a little bit with the Baxalta facility and being a non-diagnostic clinical laboratory, and it was listed within this same code. So does anyone have any questions?
Okay, questions for Representative Lott? Wow.
That's good.
Okay, guess you got, pardon? This is the proper time. Okay, we have the motion do pass for House Bill 210. Do I hear a second? Okay, we have a second. Any who? Robbie. Okay, it's time for discussion. Representative Broadwood.
Thank you, Madam Chair. Representative Lott, in compliance with the federal guidelines, that is, the federal guidelines are to assure patient safety, is that correct?
Yes, sir, that is correct.
And staffing requirements there are to have trained, adequate staff on site?
Yes, sir, that is correct.
Okay, thank you.
Thank you.
Okay, so we're ready for a vote. Everyone in favor of the passage of House Bill 210, say aye. Aye. Anyone opposed, say no. Okay, the ayes have it. Thank you very much.
Thank you. Thank you, members. If you had just read it yourself, it probably would have been easier.
Okay. And our last thing, and if we move pretty fast, I have House Resolution 170. I think most of you were here when we had the presentation on chronic fatigue syndrome and how devastating that can be. This is an urging resolution urging our state agencies, our physicians, our medical schools to look into this issue, when possible, to have further education, further research into this very devastating disease. I'll be glad to answer any questions. And it is simply an urging resolution, which will probably get lots of comments in rules. So anyway, so I have a move to do pass. Do I have a second? We got a second. Is there any discussion? Okay, everybody in favor of the passage of House Resolution 170, say aye. Aye. Anyone opposed? No. The ayes have it. Thank you very much. We are dismissed. You make up a little time for last time's meeting.
North Georgia, they call that